Welcome to the United Leukodystrophy presents Genetic Counseling for the Leukodystrophies with Julie Cohen from Kennedy Krieger Institute.
Hi, good afternoon, everyone. Thank you so much for joining me, and thank you again for giving me the opportunity to speak with you guys today. I wish I could see everybody's beautiful smiling faces, but I will just have to imagine you all out there in the audience. So I'm a genetic counselor from Kennedy Krieger Institute in Baltimore. I work as part of the Moser Center for Leukodystrophies, and I've been a part of this clinic for quite a few years now, and I've really become passionate about working with individuals and families who are affected by leukodystrophies. So I'm excited to have this opportunity to speak with you today. I have information that I'm going to present, and I'm going to go over some of the basics of genetics and inheritance patterns, talk to you about genetic testing and the different types of genetic tests and genetic counseling, and also spend some time talking about different family building options and reproductive options. But I would really like to tailor this as much as possible to everybody listening in the audience. You know, it's hard in this virtual format, but I really encourage you to type questions in as we go along. You don't need to wait until the end. I'm probably going to kind of address them at the end, but as the questions come up for you, please put them in the comments. That way I'll be able to address them. So I am going to start out by just kind of going over a little bit of basics genetics, because I think for most people it's been quite a long time since biology, and unless you're a nerd like me, you may not think about genetics every day. So our genetic information, I think of it like a giant cookbook to make a person, and our genome is made up of genes and DNA, and that's all packaged into chromosomes that are in the center of every cell. So using this cookbook analogy, our genetic information is like a giant cookbook that's made up of 20,000 genes, and the genes are like the recipes. And those recipes are organized into chapters of the cookbooks, and those chapters are the chromosomes. And in every cell in our body, everybody has 46 chromosomes that come in pairs, and we get one set of each pair from mom and one set of each pair from dad. And the chromosome pairs are numbered 1 to 22, and the last pair is the sex chromosomes. So women, we have 2 X's, and males have an X and a Y. So every person has variation in our DNA and in our genes, thousands and thousands of DNA differences, and most of those don't cause any sort of problem. When a difference in the DNA does cause a disorder or a disease, we call that a pathogenic variant, or what you may also hear it referred to as a mutation. But just keep in mind that everybody has differences in our DNA, and most of us just don't know it. So genetic conditions can be inherited in different ways. We inherit one copy of each of our chromosomes, and therefore one copy of each of our genes from each of our parents. And so the different patterns of inheritance, we call them dominant, recessive, and X-linked. But one thing to keep in mind is that genetic disorders aren't always inherited. Sometimes they occur new in an individual. The fancy word for that is de novo. And there's many different types of leukodystrophy, and they're inherited in different ways. So I'm going to go through each one of the inheritance patterns. So the first pattern is what we call dominant inheritance. So a dominant disorder, it's caused by a gene that's on a numbered chromosome. And if a person has one copy of this gene not working, they're going to manifest symptoms of the condition. And an individual with a dominant leukodystrophy, or a dominant genetic condition, in each pregnancy, there is a 50% chance of passing on that changed gene, and the child would predicted to be affected at some point, and a 50% chance of passing on the normal gene copy for the child not to have the condition. And with a dominant condition, the risk or the chance of passing it on and developing the condition is the same in males and females. So in contrast is a recessive genetic disorder, and many of the leukodystrophies, probably most of the leukodystrophies, are recessively inherited. So what recessive means is that the condition only happens, it only causes symptoms when both copies of a particular gene are not working. And an individual who has one non-working gene copy, but one working copy, they are unaffected, and we call that person a carrier. That second copy of the gene is sort of like a backup copy. And it's important to know that every single person is a carrier for probably several genetic recessive conditions, and we just don't know it. And we really never know it unless you happen to have a child with somebody who's a carrier for that same recessive genetic condition. And when both members of a couple are carriers in each pregnancy, there's a 1 in 4 or 25% chance that the child would inherit both abnormal genes and have the condition, and then a 75% chance that the child would be unaffected, either a carrier or not a carrier. And similar with a dominant condition, the risk or the chances are the same for boys and girls. It's not affected by gender. So another inheritance pattern is called X-linked, and this is caused by genes on the X chromosome. And an example of this is adrenoleukodystrophy. And probably some of you listening in today, that is your leukodystrophy diagnosis or your family member. So remember, with X-linked conditions and the X chromosome, men only have one X chromosome, so they only have one copy of that gene. And if that only gene copy is not working due to a genetic change, he is going to have the condition. Whereas a woman with 2 X chromosomes has that backup copy and may not show symptoms or may just have a milder form of the condition. So this is showing the chances of passing the condition on when the mother's a carrier. So a woman who's a carrier, each of her sons have a 50% chance of inheriting the changed gene and having the condition, and each of her daughters has a 50% chance of being a carrier. And overall, if you take out gender, it's a 25% chance in each pregnancy to have a child with that, to have a male child with that condition. And for a man who has an X-linked genetic condition, all of his daughters would be carriers and none of the sons would be affected. And that's because this man's only X chromosome has the non-working gene. And so if he passes on that X chromosome, that child is going to be a girl, a daughter, and she is going to be a carrier. Whereas his sons inherit his Y chromosome and a presumably normal copy of the gene on the X chromosome from their mother. So those are the main types of inheritance patterns. So now I'm going to go on. So that was kind of your basic review of genetics, going back to high school biology. So now I'm going to go on and talk about genetic testing and counseling. So there's a number of reasons why for a leukodystrophy, it's important to have a specific leukodystrophy diagnosis. It's important so that you have information about what to expect in the future, different treatment options and medical management, to know the inheritance pattern and the risks to family members and future children. Leukodystrophies are often can be suspected based on MRI findings. There's also tests that can be done, like biochemical tests, looking at enzymes or looking at very long chain fatty acids. But ultimately, all leukodystrophies are caused by changes in genes. And it is important, when, if possible, to pinpoint the exact genetic change, which DNA letter is changed. And that's important for carrier testing or predictive testing for relatives who are at risk, and also to utilize reproductive options. And there's a whole bunch of different types of genetic tests, and probably many of you or your family members have been on a long diagnostic odyssey trying to get to a specific leukodystrophy diagnosis. Some of the tests that are performed when trying to figure out the leukodystrophy type are what we call biochemical tests. So this isn't looking at the actual gene. This would be looking at the product of the gene or a marker in the blood or in the urine that could indicate that particular leukodystrophy. There's also tests that look at chromosomes to see, are there the normal number of chromosomes? Are there any extra missing pieces of chromosomes? And then there's tests that are looking at specific genes at the DNA level. And there's different levels at which you can look at DNA or genes. And it's important to keep in mind that not all genetic tests are the same. If we know what the leukodystrophy diagnosis is in the family, and if we know the particular genetic variant, relatives can be tested just for that one specific gene change. If we're trying to establish a leukodystrophy diagnosis and we suspect a particular type of leukodystrophy, we may test for that one specific gene. So for example, with adrenal leukodystrophy, we would know to zoom in on that one particular gene. Nowadays, in individuals with leukodystrophy, sometimes they have much broader genetic testing. Instead of trying to go one by one and check for each possible condition, the tests look more broadly and may be a panel looking at a large number of genes all at once, or often in individuals with undiagnosed conditions, they have a very broad test called exome sequencing or genome sequencing, and that looks at the important parts or nearly all of the 20,000 genes, or looks at all of the DNA. So there's different types of genetic testing situations. So sometimes we are doing a diagnostic test where we have a patient or an individual with a leukodystrophy, and the purpose of the test is to identify that specific diagnosis or identify their gene change. In some contexts, we're doing genetic testing to predict whether or not a person has the condition or will develop it in the future. So an individual is not yet showing symptoms, but they're at risk, maybe because of a family history. And then there's testing for carrier status to know whether an individual carries that condition and could pass it on. So as I said before, genetic testing is not all created equal. There's many different types of genetic tests. And genetic testing isn't just another blood test. You know, it's not as always simple as checking your CBC. And there's a lot of implications of results, and sometimes also the results may not be clear. We can get some uncertain or unexpected results. So when you're going into genetic testing, I definitely encourage you, when possible, to talk to a genetic counselor or have a genetic counselor as part of your healthcare team, because really we want you to be able to understand the benefits and the limitations, as well as, you know, the risks of undergoing testing. Knowing that genetic test results, they have implications for the whole family often. And that sometimes we don't get a clear answer from genetic testing. Sometimes we do get a clear positive result. We may find an uncertain result or something unexpected, and sometimes the genetic tests come back normal. But it's also important to keep in mind that even if a genetic test comes back normal, it doesn't mean that we're not dealing with a leukodystrophy. As some of you probably know, there are leukodystrophies that we just can't diagnose or figure out right now. And so that can certainly be frustrating for patients and families on that diagnostic odyssey. So the decision whether or not to undergo testing, it's a complex one. So, you know, when you learn you're at risk or your child's at risk, there isn't a right way to feel, and individuals respond differently. So some people, when they find out a family member has a leukodystrophy, will not want to get tested and will avoid it. Others are going to want to go ahead and get testing right away. Although that decision is really personal, remember that the goal of testing is to help you seek treatment as early as possible, to prepare for the future, to seek counseling about having children if that's important to you, and reproductive options. And then also keep in mind that for those who test negative, testing can provide reassurance, and so you don't have to worry about that condition in the future. So a question I get asked a lot is about genetic testing in children. And this is kind of a tricky issue. Typically, so if a child has a leukodystrophy or suspected leukodystrophy, of course, we're going to offer and recommend that diagnostic testing. But when it comes to carrier testing or predictive testing for a later onset condition, we usually don't recommend testing a child unless there's something that we would do in childhood to help them if they tested positive. So for conditions where we're talking about considering as a child a carrier, you know, if we find out that child's a carrier, we're usually not going to do anything differently for them while they're a child. And so it's often better to defer that and let the child, when they're older, a teenager or an adult, be able to make that decision for themselves. But there's always exceptions to that, and it's not necessarily a hard and fast rule. And if you, so we'll definitely have the discussions with families if they're interested in getting their children tested. We'll talk through it and, you know, the kind of motivations, and talk through the benefits and limitations. So now I want to talk to you a little bit about what genetic counseling is. Some of you may have worked with a genetic counselor, but there's not a lot of us around. And so sometimes you may not have worked with a genetic counselor. I think there's a misconception that genetic counseling is, something like you see in this cartoon here. So genetic counselors, or let me just start by saying, what is genetic counseling? So genetic counseling is the process of helping people understand and adapt to the various implications of a genetic condition. And what genetic counselors do is interpret family and medical histories to assess the chance of a condition, of it happening or happening again, to educate about the inheritance pattern and testing options, and counseling about making informed choices and adapting and coping with a condition. So genetic counselors, we are master's level health professionals, and we have advanced training in medical genetics and counseling. We're not doctors, but we work as part of your healthcare team to help you understand your genetic risks based on your family history, your risk for certain conditions, whether genetic testing might be right for you, and what the results of those tests may mean for you and your family. And we also, because we're trained in counseling, can provide emotional support as you make decisions, and empower you with information for your healthcare. So in the last part of the slides that I put away, the last part of the slides that I started with here before we get to the questions part, is I'm going to talk about the various reproductive and family building options for individuals with leukodystrophy. So I kind of group the options in four different groups. So one option is pre-implantation genetic diagnosis, or pre-implantation genetic testing, PGD or PGT. So what this is genetic analysis of cells from an embryo that was created through IVF. IVF is actually, I think I have another slide where I talk about what IVF is. So an advantage of PGD is that it allows identification of embryos without the genetic condition, and then only those unaffected embryos would be transferred into the woman to start a pregnancy. PGD is very accurate, but we still recommend testing during the pregnancy to confirm that result. Keep in mind that PGD, it's only an option if the specific leukodystrophy diagnosis and the specific genetic change is known. So for somebody with an unknown leukodystrophy, a test like PGD is not going to be possible. And PGD, sometimes it does require samples from more than one family member. So the first part of PGD is actually the IVF, or the in vitro fertilization. And in IVF, the female partner receives medication, usually oral and injections, to regulate her cycle and stimulate ovaries to produce multiple eggs. And women going through IVF are monitored very closely with ultrasounds and blood tests. The eggs are retrieved through an outpatient procedure, and the male partner provides a semen sample. And then in the lab, those eggs are fertilized by the sperm through a fancy process called ICSI, where a single sperm is injected into the egg. So those early embryos are allowed to grow in the lab for several days. So that's the typical IVF procedure that most commonly is done for couples who are having difficulty getting pregnant on their own. In PGD, there's an extra part of that where the genetic testing is done. So in PGD, the embryos are, they call it biopsied. Basically, a few cells are removed from each early embryo. Usually the embryo is then frozen, the embryos are frozen, and the genetic testing is done on those, on the cells from each embryo. And then the lab can determine which embryos have the genetic condition and which don't. And then in a subsequent cycle, the embryos, one or more embryos, would be thawed and transferred to the woman's uterus to start the pregnancy. So this is just a visual representation of what's going on there, where a sperm is injected into the egg, and the early embryo grows, and they remove some cells and do testing on the cells. And this is a picture of what's happening under the microscope, and it's pretty wild. you can actually Google, and on the internet, there's like videos of this happening in real time. It's really amazing that some cells can be removed from each embryo without damaging the rest of the embryo. And within those cells, you can test for many different genetic conditions, single gene disorders, chromosome problems, determining gender. But in the context we're talking about today, it would be checking for a specific leukodystrophy that's known in the family. So the advantages of PGD is that it greatly increases the likelihood of a birth of an unaffected child without termination of an ongoing pregnancy. So in the next group of slides, I'm going to talk about the prenatal testing. But once, of course, the pregnancy is already started, we can't fix the gene, or we can't fix the leukodystrophy. PGD is also very accurate. So the disadvantage is that you do have to go through the IVF process, which is maybe not as fun as doing it the old-fashioned way, and it does take quite a bit of effort. And also, IVF doesn't work every time, and sometimes couples may need to go through multiple cycles in order to get enough eggs and get enough embryos that are unaffected. PG also is very expensive, and it may or may not be covered by insurance. So I have given this sort of presentation a lot, and I always get the question of how much does it cost? So it varies widely, but just to give you a ballpark, an IVF cycle itself may cost around, I think the average cost according to the ASRM, the American Society for Reproductive Medicine, is around $12,000. There's additional costs for the ICSI and medications. And then on top of all of that, there's the actual PGD part of it, the genetic testing part of it. So it all adds up to quite a bit, and that number is extremely daunting. But an important piece of advice is, if you're interested in doing PGD, don't assume that it's not covered. Some insurance plans do cover it. And so I would encourage you, if you're thinking about PGD and wondering if this might be the right option for you, is to have a consultation with a fertility center that offers PGD. And they not only can they advise you in more details about the process and the success rates, but would be able to look at your insurance and give you a better estimate of what your cost might be. So, and also keep in mind that there are resources available for individuals who are having financial difficulties with PGD. So some IVF clinics have refund programs, there may be discounts. There's actually financing for fertility treatments. Just like you can finance a car, you can finance your IVF cycle. And there are some grants available, various grants, and people do crowdfunding too. So a great resource is the National Infertility Association, or Resolve, and on their website they have lots of resources on their website, but some of it is, they do have a page just about financial resources, so you could check that out. So the next group of options I'm going to talk about is prenatal testing, or prenatal diagnosis. So this is testing done during a pregnancy. So a couple would get pregnant the old-fashioned way, and you can do testing of the fetus either during the first or the second trimester. And that would allow you to determine if the baby or the fetus is affected with the leukodystrophy. So there's two different procedures that can be performed. Generally, a woman would have one or the other, not both. Chorionic villus sampling, or CVS, is done around 11 to 13 weeks, and amniocentesis is done a little bit later, around 15 to 20 weeks. Both of these are very accurate, though there is a small risk of miscarriage because it's an invasive procedure. Prenatal testing is only possible if you have a specific leukodystrophy, diagnosis, and usually you also need to know the specific gene mutations. So in CVS, what's happening is that it's taking cells from the chorionic villi, which is kind of like part of the placenta. And this is obtained by a needle that goes through the woman's abdomen, or a catheter going through the cervix. This is all done under ultrasound guidance, so they make sure that they're not poking the baby. But they take a little bit of this chorionic villi tissue, and then genetic testing is done on the cells from that tissue. So it's a really quick procedure. It's done under ultrasound. It's a it's not extremely painful. It's going to hurt a little bit when the needle or the catheter is going in, but it's over pretty quickly. And this is done at the end of the first trimester, and the risk of miscarriage is about 1 in 200 or 0.5% or less. And then it usually takes a few weeks to get the genetic test results. So you're probably getting results in the beginning of the second trimester. Amniocentesis is done a little bit later, and in this they're getting some of the fluid from around the baby because that fluid contains skin cells. And this is also done with a procedure under ultrasound guidance where the doctor is using a needle to go through the abdomen. There's also a risk of miscarriage with this one. It's maybe 1 in 300 or less. And whatever prenatal testing center you work with, they would be able to give you their specific numbers. So the advantages of prenatal diagnosis is that it's very accurate. I think it's more likely to be covered by insurance than PGD is, but the disadvantages is that, unfortunately we can't fix that gene. And so the option would be to terminate a pregnancy, which is not something that everybody would consider. And also the earliest time for results is going to be the beginning of the second trimester. So another option is to use donor eggs or donor sperm. So why would you use a donor? So for a man with an excellent condition like ALD or AMN, using a donor sperm would allow the possibility of having a non-carrier daughter. For a couple who are both carriers of a recessive condition, or when prenatal diagnosis or PGD either aren't options that the couple would consider or they're not able to access them, using unrelated donor sperm would be a relatively lower cost way of reducing the chance of an affected child. And then for couples where the leukodystrophy diagnosis is unknown, but the woman still wants to carry a pregnancy versus adopting, an option would be to use donor gametes. And there may be other scenarios as well, but those are just some examples. So donor eggs and sperm are available from storage banks. Donor can be tested for genetic condition, but nobody's tested for everything when they become a donor, so you have to talk to the cryo bank to see what they test for. Donors can be anonymous or known, and donor sperm can be inseminated directly into the uterus or used in IVF procedures. And for donor eggs, you would have to be by IVF. So the last option to talk about is adoption. There are a number of resources out there to learn how to start the process of adoption and what's involved with that. And so I just put up here one website where if you want to kind of find some more information about exploring what that process involves and what that might be like, this is one place to start. So those are the 4 groups of options. It's a lot to consider, and there's many different things that factor into the decision about whether or not to have children when there's a genetic condition in the family, and what steps to take to try to prevent passing the condition on. It's a very personal decision, and and members of a couple, they may feel differently about it as well. So I would definitely encourage speaking with the genetic counselor. And if you're really struggling with that decision, the couple could seek out couples therapy to really talk through that decision. And then if you're just want to explore what those options are, maybe want to know for your particular situation, what are the options? What would it look like for you? What are the chances of success? The risks with the procedures is to speak with a center that could perform those procedures, either a prenatal center or a fertility center, if you're looking at PGD or using donors. So I intentionally left lots of time for questions because I really didn't want this to be just me up here presenting a bunch of slides to a blank screen. I imagine that people, the various people in the audience have different leukodystrophy diagnoses and different questions. And so I wanted to kind of present some foundation information and then have plenty of time to answer questions. So I put up here some resources. One is the National Society of Genetic Counselors, and that's where you can find a genetic counselor near you. And they have a very handy website that's called findageneticcounselor.com. And, you know, also a plug that right now from Kennedy Krieger, I'm able to do telehealth genetic counseling visits, and Kennedy Krieger does accept many types of insurance. So if that's I can answer kind of general questions on this stream, but if you would like to get a more specific consultation, in addition to looking for a genetic counselor near you, you can also reach out to Kennedy Krieger and we may be able to set something up. And I have my email address on the next slide. Really the best resource for information about leukodystrophies is the ULF, but I don't need to put that website up here. If you're looking for you know, where to find information just about general genetics concepts or terms, another good website is Genetics Home Reference. So this is my email address. I really look forward to answering your questions here through the live comments, but you guys are welcome to email me. And so that's my email address right there. So it looks like we already have some comments in the box. Let me look at what the questions are right here. So I'm just trying, there's so many good questions. I'm just trying to decide which one to start with. Okay, so one question is, does insurance cover expenses for other family members to get screened? So usually one person's health insurance, they may cover expenses for that one individual who's insured, but probably is not going to cover for somebody else in the family to get screened. That would need to go through their own insurance. But it is really important to, you know, for family members who are at risk to find out their status. Man, I wish we could like talk back and forth so I could get some more context about what you were getting at with this question. So I guess what I would say is if there's individuals in your families who are at risk and want to be screened, but are having difficulty accessing that, to work with a genetic counselor who may be able to help you or them navigate that process. So another question is, I'm asked by a lot of families who get diagnosed through newborn screening, who should be referring the other family members to get screened? So I guess this is kind of related to that first question about, you know, when a baby gets diagnosed in newborn screening, there's, like, if we're thinking about a condition like adrenal leukodystrophy, that's X-linked and it often goes through families, and there are many other individuals at risk. So healthcare providers can't reach out to family members without permission of that first individual. So we can help provide information. And sometimes what I'll do is I'll talk with the family in front of me, the parents in front of me, about who they should speak to in their family, and what to share with them and how to explain it. Your healthcare provider may be able to give you what we call a family letter, or some, you know, that they can then share with their families. But really, I think it's that the first part of the family, when their child gets the diagnosis, they need to initiate talking with their family members. Like, I'm not allowed to go, you know, reach out to somebody else in the family without your permission. Okay. So question came in that baby was just diagnosed with a leukodystrophy. First, I'm, you know, sorry to hear that your baby was diagnosed. I'm sure this is brand new for you and hard to process everything. So in this question, the genetic change was de novo, or new in the baby, and wasn't found in either parent. So the question is, what are the risks of this happening again if we have another child? So in a de novo genetic condition, it's caused by a change in the gene, but it wasn't inherited from either parent. So the chance of having another baby with that same condition is very low, but it's not zero, and that's important to know. The reason why it's not zero is that it's possible that that genetic variant is present just in a subset of mom's egg cells or a subset of dad's sperm cells. We call that germline mosaicism. So it's possible for a couple to have a second child with that same genetic variant, even though the parents themselves didn't have it identifiable in their blood. So germline mosaicism is not common. For most disorders, we don't have like a good statistic, but I generally say it's around the ballpark of 1%. So it's not super likely that it would happen again, but it's possible. So I do recommend, couples who have a child with a de novo genetic condition who are concerned about having another affected child, that in future pregnancies, you could do prenatal diagnosis, have a CVS or an amnio to check to see if that baby does have the mutation. Most likely you would get reassuring results, but you would be able to find out if there was that recurrence. Okay, so now I have two questions about variants of unknown significance. So thinking back to earlier in the slides when I talked about the different types of genetic results, genetic test results. And I also, as I said in the beginning, to keep in mind that everybody has differences in our DNA. So of our 3 billion DNA letters, there's no such thing as a perfect genetic sequence. And sometimes we can find, when we're doing these very powerful genetic tests and looking at all of the DNA, we can find a difference in the DNA, a single letter or a few letters that are misspelled, but the lab and the doctors and the genetic counselors were not sure, is that particular variant causing any sort of problem? Is it the cause of the leukodystrophy? Or is it nothing? Is it benign or normal? So this is a situation we encounter a lot, and we really have, definitely, if you have a result that's variant of unknown significance, please make sure you're working with, with a genetic counselor or with a center who is really experienced in leukodystrophies. So sometimes we take into account, or we always take into account the clinical information and the MRI findings to see, is this patient's, is their MRI findings and clinical presentation consistent with that particular disorder? Sometimes we recommend testing family members to see if that genetic change is found in individuals without leukodystrophy, which would suggest that it's probably not the cause. Or does it track with, if there's multiple individuals in the family with leukodystrophy, does it track with that, with the affected status? Sometimes there may be additional tests to try to clarify. So if think about the example of adrenoleukodystrophy, where we know which gene it is, the ABCD1 gene. But so we may have a person who has ALD, and we do the genetic test and we get a variant of unknown significance. So with ALD, we can also do the biochemical test looking at VLCFA. And if we have a positive VLCFA result and a variant of unknown significance in a patient who clinically fits with ALD or AMN or Addison's disease, even if the genetic testing lab is classifying as a variant of unknown significance, the clinical team may say, we know that we are confident saying that this is the cause of your disease. And so, yes, and so then the second question related to VUS's, variants of unknown significance, is if a genetic test is returning a variant of unknown significance result, should this be followed up? And yes, it should be followed up. We learn more about genetic variants and genetic conditions over time. So even if the significance of that particular DNA variant isn't known today in 2020, it may be known next year or in a few years. So definitely to follow up with genetic specialists to learn more information. So, other options when there's a variant of unknown significance result found on genetic testing. I mean, it's so frustrating. It happens a lot, and it's really hard for families to say, well, we have this change in your DNA, but we don't know, is it the cause of your condition? Sometimes it can be pursued further on a research basis as well. So I guess, you know, your team is going to do the best they can to try to make a determination about what that result means, but sometimes we just don't know, and we do just have to wait and see. Now let me see these other questions here. So a question is, newly diagnosed and don't have a genetic counselor on the team currently, and how do we find the right fit? What qualifications to look for? Yes, so assuming you're in the US, so genetic counselors, genetic counselors have completed a graduate degree from specialized training programs. So they're going to have a master's level degree in genetic counseling. Genetic counselors are certified by the American Board of Genetic Counseling. In some states, genetic counselors have licensure, but not all states. So you don't need to see a genetic counselor who's licensed. So for example, in the state of Maryland, there is no licensure for genetic counselors. So I'm not licensed, but really the qualification is that certification that you want to look for. Ideally, you want to look for a genetic counselor. So if your question is about, you know, reproductive options, you may want to be speaking with a genetic counselor who is a prenatal or a reproductive genetic counselor. If you're looking for counseling about the leukodystrophy itself, you'd want to try to find a genetic counselor who knows about leukodystrophy. Now it's hard because leukodystrophies are rare, and so you may not be able to find somebody like a genetic counselor near you who's specialized in leukodystrophy. So you can go on that website, the findageneticcounselor.com. You're also, you could ask the doctor that you're working with who made the leukodystrophy diagnosis to recommend somebody. Maybe they do have a genetic counselor that they often refer patients to. And you're also welcome to contact us at Kennedy Krieger. Okay, let's see. So, I think I've answered all the questions that have come in so far. Is there, you know, please, this is an opportunity to ask more questions. So we'll wait a minute or two. I know there's kind of a time lag from when you guys type in the questions to when we see them. But please go ahead and put in your questions. And if you don't think of your questions now, but something pops up later, you can shoot me an email. All right, everyone. Oh, we had one more question coming in. If you're looking to get educated on genetics, is the NIH website a good starting place? Yes, I love that website that I put up. That's Genetics Home Reference. Right there, the ghr.nlm.nih.gov. So that's a great website for general information about genetics and inheritance patterns. They do have information about many genetic conditions. If you're looking for information about leukodystrophy, I would recommend for sure starting with the ULF. But if you're just looking for kind of more general information, to go to that Genetics Home Reference website, that would be a good start. Okay, I'm going to give it 10 more seconds. So really, it was so lovely chatting with all of you guys today. Like I said at the beginning, I wish I could see all of your faces, but you know, that's how things are right now. We don't have the ability to do that, but I appreciate you all taking the time to listen and put your questions in. And I hope to see you guys all next year, maybe in person, or if not in person, we'll do it virtually again. Okay, everybody, take care, stay well.